to those who are joining us online via Facebook and YouTube. It is with great pleasure to welcome Dr. Sizi Mieni to our seminar on dementia this evening. This is a very serious condition that we are faced with in our communities. Not so long ago, many elderly have been killed or suspected of witchcraft. There is a lady by the name of Sabina Mbangu who had dementia and was accused of witchcraft, and she was poisoned by her own grandson, and she died. And even in the northern Zululand, there have been a number of cases of the elderly being killed because of being suspected of doing witchcraft. The grandmother and her granddaughter were killed and burnt inside the house in the Jozani area. And then in Ekulingweni, the grandfather and grandmother were shot after they were suspected of witchcraft. The grandfather died on the scene and the grandmother died in hospital after having informed the police about the identities of the perpetrators. And in Soweto, a 59-year-old Justina Sangweni was also beaten to death after being accused of witchcraft. So there are many cases, and there's another 80-year-old lady, Domisile Mahlangu, who was locked in her home and set alight by the community of Mbuzini because of the dementia. But we have the privilege of learning this evening from Dr. Sizi's insights and expertise, and I'm confident that her presentation will be enlightening, will be informative and thought-provoking. So we have a unique opportunity to gain a deeper understanding of this condition. Shall we open with a word of prayer? Loving God, as we gather this evening for this dementia seminar, we come before you with hearts filled with gratitude and hope. We acknowledge that you are the source of all knowledge, of all wisdom, and we seek your guidance as we delve into the complexities of this challenging condition. We recognize that dementia touches the lives of millions of individuals and families around the world. And we pray for your compassion, for your comfort, to be with all those who are affected by dementia. Grant them the strength to face the difficulties and uncertainties that dementia brings. And may they find support and understanding in their journey. We are grateful for the opportunity to learn from professionals, from health workers like Dr. Sizi. We pray that her insights and expertise may shed light on new ways to improve care, treatment, and support for those living with dementia. Now, as we engage in discussions and share knowledge during this seminar, may our minds be open to new ideas and perspectives. Help us to approach this topic with sensitivity and empathy, recognizing the dignity and worth of every individual impacted by dementia. We also lift up in prayer the caregivers who tirelessly devote themselves to the well-being of those with dementia. Grant them patience, strength, and moments of respite amidst their responsibilities. May they find solace in knowing that their efforts are valued and cherished. So, Lord, we ask you for your blessings upon this seminar. May it be a space of enlightenment, of collaboration, and compassion. Finally, we offer our thanks for the gift of life and the precious memories we hold dear. Help us to cherish each moment and to foster a world where compassion and understanding are extended to all, regardless of their cognitive abilities. In the name of your Son, our Savior, Jesus Christ. Amen. So without further ado, let us extend a warm welcome to Dr. Sizi. And thank you, Doctor, for gracing us with your presence and your willingness to share invaluable knowledge with us this evening. So we eagerly await your presentation and look forward to the discussions and discoveries that we unfold throughout this seminar. Thank you. Shall we welcome Dr. Sizi with a round of applause? Thank you.
Good evening, everyone. I'm so happy to be back. The first time I was here was it last month? No, the month before. 2 months before, yeah, for the autism talk. So I'm very happy to be back, and I hope that what I have to bring you today is going to be helpful to some of you and maybe bring hope to some of you as well. So this is just an outline of what I'm going to talk about today. Dementia is a big topic. There's a lot to cover. I'd be here for hours if I had to go through everything, but I'll try to keep it short and relevant. And it's very relevant that we actually be talking about Alzheimer's today and dementia, because September is actually known as World Alzheimer's Month, which is an annual international event. And the theme this year is very nicely, never too early and never too late. So this theme focuses on identifying risk factors and how to reduce risk factors for dementia. In general, it's thought that dementia has poor understanding. And so the aim of Alzheimer's Month is to raise awareness and to challenge stigma around dementia. It is also an opportunity for everyone to come together and to work together. You know, individuals living with dementia, caregivers, communities, the government, in order to fight stigma and to provide support, and hopefully to also lobby the government for better services for people living with dementia. I don't want to scare anybody, but before we dive into exactly what dementia is, I just thought, let me give you a little bit of anatomy. This is your brain. And your brain has a lot of functions. And without confusing you too much, basically what is important for you to remember is that the brain does a lot for us, from memory, from planning, from even running our personality, helping us with reasoning, helping us with making judgment calls. Our brain helps us with all of that, with language, with hearing, with vision. We wouldn't be able to do any of that if it wasn't for our brain. And what is important for you to remember is that in medicine we have this group of functions in the brain that we call cognitive functions. And cognition is essentially the work that the brain does for us. And this involves things like thinking, things like attention, like remembering, like judging, like being organized, like planning, even things like our ability to recognize emotions in other people. That all falls under cognition, and all of that is run by your brain. So what is dementia? Essentially, dementia is a collective name, or what we call an umbrella term, for conditions in which there is a progressive loss of normal brain function. And this results in physical and chemical changes in the brain. Now, these changes then affect a person's memory, affect a person's thinking, affects their behavior, their emotion, and even their ability to live independently. And dementia is not part of normal aging, and that's what makes it a disorder. According to South African stats in the 2011 census, there were approximately 2.2 million people in South Africa living with dementia. And it's been estimated that in 2050, there will be more than 139 people with dementia in the whole world. That's a big number. Nowadays, in medicine or in psychiatry, we don't really use this term of dementia. But rather, when we talk about these conditions that affect our cognition, like I explained what cognition is, we use a term called neurocognitive disorders. And that, again, is also an umbrella or a collective term, and it can be divided into what we call major neurocognitive disorders or minor neurocognitive disorders. And like the word suggests, something that is major is big, and that is where it starts affecting your ability to be independent. And something that is minor is, I guess, smaller and doesn't really affect your ability to be independent. So this old term for us in medicine of dementia has now been replaced, and we call it neurocognitive disorder. In case anybody has ever said that to you, or in case any doctor ever mentions it to you, it's pretty much synonymous with dementia. So there's your umbrella. Like I said, dementia is an umbrella term, and under this umbrella, we have various smaller, similar, but different types of dementias. So dementia is the big term, and underneath it, there's Alzheimer's, there's vascular dementia, there's frontotemporal dementia, there's a whole long list of different types of dementia that differ a little bit in their symptoms, they differ in what we see when we do brain scans, and they differ in how we manage them. But largely, their symptoms are similar. And the two commonest types of dementias that we have are Alzheimer's disease and vascular dementia. And I'm sure most of you have heard of Alzheimer's disease. This is by far the most commonest type. It makes up about 50 to 60% of all types of dementia. And the biggest and most significant risk factor for Alzheimer's is age. The majority of Alzheimer's disease occurs above the age of 65. However, there is that very small group that does occur early on, and we call that early onset Alzheimer's disease. And that can occur even in someone as early as 50 years old. These early onset times are the ones that generally is thought to be linked to genetics. But the others, it's not really known exactly what causes them. And then vascular dementia is the second commonest type of dementia, and that accounts for about 30% of all dementias. This one is important as well because it is caused by strokes or multiple mini strokes, and often this occurs in individuals with hypertension, if it's not controlled, diabetes, if it's not controlled, or heart conditions, if they're not controlled and well taken care of. So an individual can have a big stroke, or sometimes they can even have multiple little strokes and not know. And then slowly over time, they might end up developing a dementia, and that is what we call vascular dementia. So as I said, we have this umbrella term of dementia, and as we all know, we are all different. We are all unique, some more than others maybe, and dementia affects people differently. So no two people will have the same symptoms occurring in exactly the same way. In addition, symptoms do differ across these various types of dementias, but largely the symptoms are similar. So now I want us to just take a little bit of a look at what are these symptoms that I'm talking about. So the symptoms we're going to look at are those of memory, language, thinking, emotion, behavior, and very importantly, activities of daily living. Memory loss is the most common and earliest sign of dementia, and it's also progressive, which means that it carries on slowly over time, getting worse and worse. And this memory loss can eventually lead to individuals withdrawing or isolating themselves from family, from friends, even at work. Memory decline is more in terms of what we call short-term memory. So you may find that an individual who has Alzheimer's or has dementia, they will be able to tell you something that happened 20 years ago and tell you with great detail. However, you may ask them at 1 p.m. what they had at 8 a.m. for breakfast, and they won't be able to tell you that. The decline in memory can also lead to what we call disorientation. And now when we talk about this disorientation, we talk about how there's this disorientation to people, to places, to time. For example, they'll start getting lost in familiar places. They may even confuse day and night and not really know how to tell the difference, that it's dark outside, it's nighttime. And the other thing that also occurs with memory loss is misplacing things. Often they'll forget where keys are, and we all do that sometimes, but it's about how often it starts happening. You may even find they put things in strange places, like an iron in the fridge, for example. That has happened to some of my patients. And a typical example of memory loss that is associated with dementia is an individual with a normal type of forgetfulness. They may bump into a neighbor, and for a time, for a moment, they may forget the neighbor's name, but they'll know that this individual is their neighbor. But a person with dementia, they won't even be able to recognize that this individual is actually their neighbor. They'll forget the name, they'll forget that the person is their neighbor as well. And then with regard to language, people with dementia will often forget simple words. And often you find that they'll start substituting words in their sentences because they can't remember the right word to use. So this starts often affecting them at work, where it might be difficult for people to read things that they've written because maybe they've written a word that doesn't exist or the wrong word in the incorrect context. With thinking, there's this poor judgment. So, for example, you may find that in a cold night like this, they will wear very light clothing and just wear one layer of clothing. But on a very hot day, they put on lots of clothing. So there's that poor judgment that happens in individuals with dementia. They also have difficulty with concentrating. That's also a very common symptom that families actually report. They struggle to start making decisions and solving problems, and this becomes a big problem in terms of finances, where you find that individuals before were able to pay their bills and pay their bills on time. They're able to do cell phone banking and all of that, go to the bank, go to the ATM by themselves, but over time, they aren't able to do such things that they were able to previously do. There's also this disorganized thinking, which can take the form of hallucinations, so maybe seeing or hearing things that other people around them don't, or delusions where they may believe in things that are not necessarily true. And these become very important because often they're then seen as being psychotic. And it's not necessarily that they are psychotic in the sense of having this primary psychotic disorder, but it's just that they have, often it's auditory hallucinations that they'll have in the context of all this other cognition that is also happening. Emotions, generally there's this change that takes shape in a form of personality as well as mood changes that is outside of who the individual is known to normally be. And this can take form in depression. Depression is very common. And depression can happen in two ways. Often you find that depression can occur in the very, very early stages of dementia, or it can actually occur as a result of the dementia. Depression is common, anxiety is also very common, and just general mood swings and a sense of being more irritable than usual. They also show less emotion sometimes and become very withdrawn, as I had said. Behavior, I think maybe the behavior is more why families end up bringing their relatives to the hospital. The memory sometimes can just be pushed off as being part of old age, but it's when the behavior starts becoming a problem that then families bring individuals to the hospital. And you get this fluctuating behavior, so it kind of comes in waves, comes and goes, comes and goes. And it essentially affects and makes it difficult to perform tasks that were previously familiar to them. For example, even just preparing a meal that they've prepared 1,000, 1,000,000 times before can start being something that's very difficult for somebody to do. There may even be changes in sleep patterns where at night they're not sleeping the way that they used to sleep, and they can become quite disruptive at night to their family members. Something that becomes quite a problem and scares families a lot is aggression and agitation that can also occur. And often this is actually due to frustration. Frustration at not being understood, frustration at feeling scared, frustration at feeling humiliated. And 99, probably even just 100% of the time, this aggression and this agitation is not deliberate. They're not doing it to upset anybody. They're not putting it on. It's happening because they themselves can actually sense that I am not being understood and I cannot make myself be understood to those around me. So it becomes very frustrating, and then it comes out in these ways. And as the disease progresses, individuals also struggle with what we call activities of daily life. And these can take two forms. We call them instrumental activities of daily life. And those are more difficult, I guess, things to do, like the shopping, like the finances, like the household chores. And then we've got basic activities of daily life where it can, as time goes on, it can become difficult to bath, to dress, to feed oneself as the disease progresses. And now just to take you through a little bit of the clinical stuff that we do at work. So when relatives bring in their mother, their father, their grandmother to the hospital, we then have to make a diagnosis. And diagnosis can be very difficult, especially in the early stages. And also because there are many disorders that present in a similar way to dementia. You can imagine if, like I said, like the memory loss can be put away as old age. But maybe if you're becoming aggressive and you are starting to see things and hear things, a relative will come in and that's what they will tell you. And as a psychiatrist, my mind will go to start thinking that, is this psychosis? So it's very important that we then have to make sure that we tease out all the signs and symptoms that are being presented to us, because it could be anything before we go on and jump to say that this is actually dementia or this is a neurocognitive disorder. So in psychiatry, we rely on our book there called the DSM. It's what we use essentially it's a tick box for us. It's a tick sheet. So whatever is presented to us, that's where we go to say, okay, this individual ticks this box and this box, therefore this is the diagnosis that we're going to give. Sometimes it fits the boxes perfectly, sometimes it doesn't, and we always have to also use our clinical judgment to make the right call. First, we always have to make sure that we talk to the family and get the whole history of the individual, because like I said, dementia is a progressive illness, and an individual won't be brought in today, they'll come in 10 years later, whereas symptoms actually did start today. So we will want all that history dating back from all those years ago in order to make sure that we have the right diagnosis. And often then we also don't just speak to that individual family member that's there, we'll also extend it to other family members that live with the patient. If it's somebody who's working, often we also want to find out at work how the individual is functioning, obviously with their consent, if we can speak to their colleagues. We also do a very thorough physical exam because, like I said, symptoms and signs of dementia also can smell and sound like symptoms and signs of anything else. So we always want to make sure that we're not dealing with something else that rather needs medical or surgical attention. And then we do something in psychiatry that we call a mental state exam. And that's not really a physical exam, it's more an interview, but they just call it a mental state exam, where we then ask the types of questions that we can then elicit. Are there delusions? Are there hallucinations? How is this individual's judgment? Basically all the questions that we need in order to gauge what is the cognition of this individual. And then we'll do some blood tests, and for most patients, we'll also then send for a CT scan. And one of the very important investigations that we do, unfortunately you can't see it very well there, but this is a screening tool that we do. It's called a mini mental state exam. And this tool it doesn't help us to diagnose, but it does help us to get an idea of what could possibly be going on. So it tells us that there is something wrong with the cognition, but it doesn't tell us exactly what is wrong. But through asking all these questions, we then basically can understand, is this person orientated? The first questions there are simple things like, what is the year? A person with dementia doesn't know what the year is. They don't know what the date is. They don't know what day it is. They don't know what season it is. They can't tell you if it's day or night outside. So that's what we ask. We ask questions to help us identify if there are any language problems that are going on. And once we've done all of that, it's a very quick test. We can then score. And depending on the score, we then have an idea of, firstly, is there or isn't there any cognitive impairment? And secondly, how bad is it? But like I said, it doesn't exactly tell us what is causing it. It just tells us that there's something going on that we need to have a closer look at. This is a lot of words and complicated. It's taken directly from the DSM that I was talking about. This is the text sheet that we use to diagnose major neurocognitive disorder or to diagnose dementia. And essentially, if an individual fulfills this criteria of saying that there is cognitive decline, we've done a screening test like this mini-mental that I was telling you, and it shows us that there's a decline, and there are problems with their ability to live independently, then that highly suggests that we are dealing with an individual with dementia. So I quite like these next three pictures that I'm going to show you. I feel like they're quite an accurate depiction of the progressive loss of memory and of cognitive functioning that happens over time. So you can see this as kind of a full brain, and these are the early stages of dementia, where a person doesn't really have signs or symptoms, but actually inside the brain there's a lot that's happening already, and I will show you a video about what exactly is happening in the brain. And then over time, it can take up to, like I said, even 10 years, that then you get to the second stage of dementia, where there's just this progressive, slight memory loss that is happening, till eventually you get to the third and end stage of dementia, where there's poor communication, they aren't able to recognize their family members, they can't live independently. I think this is a nice video. I hope it's going to play. It will summarize everything that I've said very nicely and put it in a nice visual format. Not playing? Okay. Let me see. Yeah.
Maybe play it from there because we won't get sound.
Okay.
So what is the video?
What is Alzheimer's?
Will you come and
Maybe while we wait for the video, are there any questions so far? Yes. Anything but that. I will get to that. Yes, so that is part of the blood work that we do, and all because things like vitamin deficiencies can actually lead to some sort of cognitive impairment. Because just by saying that somebody is cognitively impaired, we're not saying that they have dementia. So that's why it's important to check all those things. And if there is any sort of vitamin deficiency or anything of that sort, then we correct it, and then we see if there's anything further that needs to be done. Yeah. If it is because of that, yes, then you will. Very early on, you can pick up, you'll see in the video
disease.
sort of what happens in the brain. Yeah.
Alzheimer's is a slow, fatal disease of the brain affecting 1 in 10 people over the age of 65. No one is immune. The disease comes on gradually as 2 abnormal protein fragments called plaques and tangles accumulate in the brain and kill brain cells. They start here in the hippocampus, the part of the brain where memories are first formed. Over many years' time, the plaques and tangles slowly destroy the hippocampus, and it becomes harder and harder to form new memories. Simple recollections from a few hours or days ago that the rest of us might take for granted are just not there. After that, more plaques and tangles spread into different regions of the brain, killing cells and compromising function wherever they go. This spreading around is what causes the different stages of Alzheimer's. From the hippocampus, the disease spreads here to the region of the brain where language is processed. When that happens, it gets tougher and tougher to find the right word. Next, the disease creeps toward the front of the brain, where logical thought takes place. Very gradually, a person begins to lose the ability to solve problems, grasp concepts, and make plans. Next, the plaques and tangles invade the part of the brain where emotions are regulated. When this happens, the patient gradually loses control over moods and feelings. After that, the disease moves to where the brain makes sense of things it sees, hears, and smells. In this stage, Alzheimer's wreaks havoc on a person's senses and can spark hallucinations. Eventually, the plaques and tangles erase a person's oldest and most precious memories, which are stored here in the back of the brain. Near the end, the disease compromises a person's balance and coordination. And in the very last stage, it destroys the part of the brain that regulates breathing and the heart. The progression from mild forgetting to death is slow and steady, and takes place over an average of 8 to 10 years. It is relentless and, for now, incurable. Helping your family, friends, and neighbors to better understand Alzheimer's will reduce stigma, improve care, and even help the fight for a cure. Thanks for helping to do your part. Learn more at www.aboutalz.org.
Yeah, so I quite like that video. I think it summarizes everything that I've said so far pretty nicely, and you can see how, going back to the first image of the brain that I showed you, and how each part of the brain has all those functions, and how you have those. So with the CT scan question, that's what you see on the CT scan, these plaques and things that start off slowly on one side, and then they go and they progressively go to other parts of your brain over years. Okay, So I've put together some commonly asked questions in case the audience was too shy to ask questions. And these are some of them. Are they visible on scans? Yeah. Yes. Sometimes not so much on a CT scan. Maybe you might need an MRI more than a CT scan, because that sees better. So lots of people ask, who gets it? Is there a cure? My mother has dementia, will I get it? How can I prevent myself from getting it? Where can I find help? And how can I help my family member with dementia? So, looking at the first one, who gets dementia? Research says it's unlikely that there is one single cause for dementia, but it's believed that there are many factors at play. There's genetics that's not really understood, there's lifestyle factors, there's age, which is really the biggest one that is known and is understood. So it's difficult to predict exactly who gets dementia and who doesn't get dementia. Anyone can get it. It's not based on your social, your economic, your ethnic, or your geographical boundaries or background. Anyone can get it. But as I've said, it is primarily a disease of older people. It affects more than 5% of those over the age of 65 and more than 20% of those over the age of 80. And I did mention that although it is possible to develop a type of early onset dementia, the chances of developing this increases dramatically with age, and this is not really well known and is mainly associated with genetics, but they're still doing a lot of studies into it. There seems to be gender that plays a role in only certain types of dementia. They have done some research looking into Alzheimer's dementia and gender, and that's all connected to menopause and estrogen levels, and that being a risk factor for development of Alzheimer's. Alzheimer's type. There seems to be a connection with that, yes. Is there a cure? So here's the answer. So at the moment, there is no cure for dementia. However, there is lots of research, and some of the research is quite controversial, but it is hoped that there will be effective treatments soon. And while there is no medication to cure dementia, there are drugs that will help with either slowing the progression, slowing the cognitive decline of the condition, or medication that helps with the symptoms that occur with dementia, all the symptoms that we spoke about, the aggression and the depression and the anxiety. And we group all of those symptoms into what we call biological and psychological symptoms of dementia. And I always like to mention that there are two types of ways in which to manage any type of disorder. And we are big on this in psychiatry. There's non-pharmacological management, which doesn't necessarily need medication. And then there's pharmacological management, which then you can use actual pills and whatever else. When it comes to dementia, the first line and most important treatment or management is non-pharmacological, is management that doesn't use medication, doesn't use pills, in order to treat these behavioral and psychological symptoms. So we always want to individualize the treatment. Like I said, yes, symptoms are similar across the board, but an individual is different. No two people present the same way. So we always try to look at the individual and try to treat the individual and not the disease or the disorder or the condition. Always important to address contributing factors, and important factors when it comes to dementia is things like pain, things like constipation. It's been said that pain often presents as agitation and often presents as aggression. And they've done trials and studies where it's even been shown that something as simple as Panado can even improve and help a person if they're being aggressive, if they have dementia, because them being aggressive is just how they are relaying their pain or they're being uncomfortable. It's also important to understand that any problem behavior is really just an expression of distress. And I've said this before, an expression of their unmet needs. It's important to keep individuals with dementia stimulated. It's not about now that they're getting lost and they're wandering away. Yes, you can be scared of that, but now it doesn't mean that they must stay at home and you can't go out with them and go for a walk, go out for dinner, or whatever that they need. Orientation is part of the stimulation, because one of the things to also go with dementia is being able to know what the date is, what the day is, what the year is. And we always encourage that there be calendars at home, that there be clocks around, that they can always know where they are, what time it is, what day it is. And obviously more for us, I guess, is just to work closely with caregivers to know that an individual isn't just an individual with dementia, but they're an individual with dementia in a family unit. So as much as we can treat them, but we also need to work with the family as well. And there's this term that we also like to use in psychiatry, which is the multidisciplinary team. And this means the working together of all kind of health professionals. So essentially, an individual with dementia doesn't just need one doctor. They need the psychiatrist, they may need their general practitioner, they need occupational therapy, they need physio, they may need social workers, they may need a couple of other health professionals to all help with getting them rehabilitated and get them well. But this is mostly what most people are interested in, is the pharmacological management. What pills can you give me? And the crux of the matter is that there's really not enough evidence for most of the drugs that are there. And in the elderly, you always have to be careful, because you always need to consider risks and benefit because of side effects. They are more prone to side effects, so you always need to be careful. And what most researchers do agree on is that the use of medication needs to be limited just to targeting certain symptoms. And that is only if the non-pharmacological management has failed. So always try things that don't need medication first before you jump to medication. I guess I wouldn't be doing you justice if I didn't mention the first two types of medication, or the first two groups of medication, the acetylcholinesterase inhibitors and memantine. So we don't have these in state. I work in public. We don't have this medication, probably because it costs a lot of money. But they have it in private. It is licensed for use in mostly Alzheimer's disease. With all the other dementia types, there are lots of T's and C's with whether you can use it or not. And it is beneficial in that it does slow the progression. But like I said, when it comes to research and medication, it's very controversial. Some will say that it slows the progression a lot. Some will say there's really not much difference. So it's all really at an individual basis. But what is there and what is licensed for use are those drugs. What we have in state are the other drugs that we use in order to manage the symptoms if the non-pharmacological part has failed. So we'll use such things as antipsychotics, which generally are used obviously for psychosis, but we'll use them in dementia if there's severe aggression. They can really help in that sense. I did mention depression and the association with dementia, so it's also very important to treat moderate to severe type of depression that occurs in dementia. Analgesia, especially with pain, that becomes important. Some doctors will want to give patients benzodiazepines. These are types of drugs that can be used to calm people down, to sedate them, to help them sleep. but you don't want to use those drugs in an individual with any cognitive problems because they actually make the cognition worse. So please just be aware if anybody ever wants to prescribe those. And then sleep becomes a problem, and generally the normal sleeping tablets that we would give don't really do patients much justice. So we may try drugs like melatonin. But again, like I said, we really are more for the non-pharmacological management in terms of, is there a cure? And then for the question of my mother has dementia, well, I get it. So it's only in a few rare cases where dementia actually runs in families, and we call those familial types of dementias, where there has been this genetic link that has been found, and then you may find that with close family members there may be a 1 in 2 chance of developing dementia, but there's still a lot of work that is going into these kinds of dementias. And then looking at the dementia risk factors, like I said, that September is Alzheimer's month, and the theme is really centered around looking at the risk factors. So I thought it's important to identify some risk factors, because although not enough is known about the actual cause of dementia to know how to prevent it, we can't really have any kind of specific recommendations for how anybody can prevent themselves from getting it. But what we do know and what we can recommend is some healthy lifestyle tips to reduce the risk of getting dementia. I did mention age, and I mentioned, a little bit about genetics, and we can't really do much about genetics, and we can't really do much about age. Those are not things that are really in our control, but there are certain things that are in our control, and there's a lot of evidence that is coming up that shows that if we can control these 12 things, we can possibly reduce the risk of getting dementia. And these are such things like physical activity. Physical activity reduces your risk of getting dementia, reduces your risk of getting heart disease, hypertension, diabetes, all of which at the end of the day also puts you at risk of getting dementia. Smoking greatly increases your risk of developing dementia, and obviously also increases your risk of diabetes, of strokes, all of which then also increases your risk of dementia. So it all goes hand in hand. Alcohol, there's this research that has found a relationship between alcohol abuse and the development of dementia, and it seems that alcohol abuse, not just normal alcohol use, alcohol abuse actually increases the risk of dementia. An interesting one, which is really for our government, I guess, is air pollution, and there's also a growing amount of research that is going into this risk factor as something that actually increases individuals' risk of getting dementia. Head injury is also very important. So in looking at the different types of dementia, there's actually dementia that occurs as a result of head injury. And in South Africa, head injury mostly occurs as a result of motor vehicle accidents or assault, and sometimes in sport. And sometimes those things are out of our control to a certain extent, but we can do what we can do to try to prevent ourselves and keep safe in order to reduce the risk. Infrequent social contact, as mentioned, that social connectedness actually reduces the risk of dementia. Through that social contact, you actually enhance an individual's cognitive reserves, and you're encouraging appropriate behavior in social contexts. So that's good. There's also research that shows that individuals with low levels of education in early life, actually this affects their cognitive functioning and therefore puts them at risk of getting dementia later on in life. Obesity, all linked with hypertension, links with diabetes, and all puts you at risk of developing, especially vascular type of dementia. And we have spoken about depression and depression is also associated with just increased disability and physical illness, and really just makes the outcome of dementia far worse. And hearing impairment. So people with hearing loss also have a significant increased risk of developing dementia, so important to recognize and to get hearing aids if needed. So where can one find help? There is actually help, and there's help nearby. There's Alzheimer's South Africa, which actually has offices in Pinetown, and there are offices in PMB as well. They offer counseling, they give information, they support group, they even do training courses for caregivers of individuals with dementia. There's Dementia SA, and they're quite nice because they actually have virtual support groups. So you can be at home and have a support group online, and they offer webinars, I think, every week or so, where they have webinars on different topics on dementia. Mutande Society for the Aged, this is a NPO that also focuses on issues that affect the elderly in the community. They're also here in Durban. One that I'm working with that's close to me is Bessie Makatini Foundation, BMF. So this is an NPO that's in Chatsworth. Also provides a lot of us, has been in work for a long time, kind of went dormant a little bit when COVID came about, but they do a lot of work and assistance with people with dementia, but also a lot of work with caregivers, which is something very important. And what's very nice with them is that they have close relationships with certain hospitals, mostly King Dinizulu, where I used to work. And the relationship that they have there is nice because if you are a member or you are known to BMF and you have any concerns, they have a direct line to us there to get you easier and quicker assistance for anything. And they are actually going to be having an event, so now I get to advertise as well. There's going to be an event that's going to be happening in September for dementia. And I brought my nephew along so that he can hand out pamphlets to everybody with regard to that event. And I really would encourage all of you to come. I think it's great. It's absolutely great they really try to include the individual with dementia a lot in everything they do. I think this time there's even talk of having a choir with the individuals with dementia, and I might also be speaking there as well. So it would be really nice if as many of you can attend, and there's a lot to learn from this foundation. I feel the talk would not be complete if I didn't talk about caregivers, because like I said, dementia, it doesn't just affect the individual, but it affects the family, affects the community, the neighbors, the friends, the relatives, everybody. And a big thing that I think people forget is that caregivers do a lot of work, and they can be stressed, they can burn out, they can get depressed from all the work that they do. And I think it's just important that if there are any caregivers in the audience, to know and recognize the signs of stress and burnout, and to get assistance, to talk, to empower yourself, to be patient, to have a plan for your daily life with the person that you're taking care of, but mostly to really just get support. There's lots of support out there. Like I said, join a support group, reach out to family members for support. And also there's the Department of Social Development that also provides financial support for caregivers of individuals with dementia. So just a word for the caregivers. They're very important. So just a short summary of everything that I spoke about, some take-home messages. Hope it's been helpful. And that's it. Thank you. Yes. Honestly, I've never heard of childhood dementia. Yeah. You always have to read these things sometimes with a pinch of salt.
So maybe it's just something else she's got, and then it's been classed as that.
Yeah, you'd have to, I guess, look at the full picture of what is happening. Like I said, I mean, with children and sport, they can get head injuries, and then there can be some cognitive impairment that happens. Could be a case like that, but to say that there's childhood dementia,
No,
I
they actually
don't-
use the word childhood dementia.
No.
So I wondered,
I'm not aware of
I'm not
that.
aware of it, so it's not a common. So obviously it's not a common. Somebody just labelled it as childhood dementia. Yes.
Yeah.
And it's interesting, you said about the head injury. I've got a very close friend. A couple of years ago, she had a bad fall. Now she's actually got dementia, and her sight's slowly going as well, and that's also apparently from the fall. So so it actually probably was the bad fall she had.
Yes.
And she sort of started with the start of it. Thank you.
Thank you.
I don't need that. Thanks. Wow, what a fantastic seminar. Just two very short questions. In the upper highway area, where would our first port of call be? Would it be Hillcrest Hospital, or what would the sort of, do you have an idea where we would go if some of those symptoms or family members?
Well, what I do know is that you always have to present to your nearest hospital, to your local hospital. But also, these support groups are very helpful in that they are the ones that also can put you into contact with the correct places to go to. But yeah, the closest in your local hospital would probably be the best place first.
Second question is probably more financial. Is most of this covered by recognized medical aids or not?
I actually don't know because I work in public, unfortunately. No, actually, that's very good. I like public. I'm in state. But with everything, as far as I know, when it comes to medical aid, as long as it has been diagnosed and there's proof of the diagnosis, then I don't see why it can't be covered by medical aid. The only hindrance would probably be that in actual fact, there really isn't a cure, so you're not curing it. So that might be the hindrance that maybe medical aids would have.
Thank you very much.
Sorry, I arrived late. But the reason for my coming here is because I've got a friend who has been living in America for over 30 years. And I visited him 2 years ago when he was in South Africa. The only caregiver for him was his wife, who since died. And now the daughter has brought this friend of mine back to South Africa, virtually, well, to die. Is it going to be, because they said that they are trying to make him come into a normal environment that's not going to be rejecting him. And I actually want to go and visit him before the end of the week. I don't even know what to say to him. Last time, he just looked at me. That's a guy who accompanied me when I went to pay lobola for my wife, and he couldn't recognize me. What is there anything that I can say to the daughter to at least encourage her?
Well, I think what probably she needs more than anything else is just to know that there are people that are there. And now that you are equipped and have all of this information, knowledge is power. So maybe you can share some of the information with her and share support groups with her the information that we have here on support groups, the pamphlets that I'm going to give, so that she can get support groups. She can either go there to support groups or virtual support groups, and she doesn't have to leave her dad alone. But if anything else, I think it's just for you to be there and to understand. And to, like I was talking about the stress and the burnout, a lot of people don't really ask for help. So if she can go for a walk for an hour while you are able to stay with your friend, that might do her a world of good. Yeah.
Okay, maybe let me hand over to Mama Mahlangu, please. Please come. Yeah. In the absence of comments or questions. Oh, this.
At diagnosis stage, or what stage do you get where, I don't know whether it's going to be the state that advises that the dementia patients cannot make any more decisions for themselves? Or when can the kids take over in terms of taking care or making decisions for the dementia patient? Because, as you said, it comes in different stages. When, as if it's your parent, you would know that, no, these things are not fine, but they have not been diagnosed, yet they're making wrong decisions. Or they're staying alone and you feel it's not right for them to stay alone. At what stage can the state or the doctors intervene and say, you know what, you as the kids can make decisions for the patient?
So are you saying that this individual lives by themselves? As soon as you are seeing that there is something wrong, number one, that this individual is possibly a danger to themselves or other people, and not just physical danger, danger in terms of their finances, danger in terms of even their reputation, you can take that individual to the hospital. And it does get difficult with police, but if at any time you feel that someone is a danger to themselves or to others, technically the police are supposed to come and help you to bring an individual to hospital if you can't get them to hospital yourself. And if you come into the hospital and you say to us that this and this and this is happening, then there really shouldn't be an issue. However, then also all we can do is to evaluate, to diagnose, to give our findings. Then the court has to get involved to take over in terms of now who's going to take over looking after the assets and all of that.
It's disappeared. Okay, we have a question from one of our viewers on Facebook. She says, which stage aggression fit into?
Which?
Stage aggression fit into?
So it's, I'd say middle and late stage. It's not an early stage, but like I said, everyone is different. And not everybody gets aggressive as well. Although it is a common symptom, not everybody gets aggressive, and everybody's different. But the earlier symptoms are really more the memory and the thinking. And the aggression, that comes later on in the disorder.
Thank you.
Doctor, you said that the aggression is the patient's. I think you said that aggression is part of the way that a person with Alzheimer's expresses their pain or some other discomfort. Is that right?
It can be, yes.
Okay.
Because it comes with the frustration, almost like, maybe it's a bad example, but a child who can't say what they want and they just have this anger outburst or they lash out because they feel that they can't verbalize what it is that they need and what it is that they want. And they can recognize that they're not being understood as well. So it's that frustration that ends up making them aggressive and agitated and irritable.
Institutions as such that demented people go into? Or do you just go into an old age home or anything like that? I mean, I know a lot of people here actually work at places, but there isn't really state run places. Okay, and then
No, so these kinds of organizations, BMF, and they try to, to get the government for years to have places, but it's kind of constant battles.
Yeah. And CBD oils, have they been used successfully?
Not that I know of, no. And remember, with obviously with CBD, it all depends on, because with that, you get two forms. You get the CBD and you get the THC. So it all depends on how much you've got of the right thing versus the bad thing. Yeah.
Thanks, Dr. Sizi. I just want to share with my fellow congregants here that my mom is 76 years old and is also struggling with dementia. And when I'm listening to this presentation, she fits in all these things because she is hypertensive, she is diabetic. What I didn't get, but I may think maybe stress. She lost a daughter in 2013, and since then we could see that there were changes. Even today, we don't know where the death certificate is hidden. We don't know where she placed it. Mm-hmm. And then 10 years later, last year, she lost my brother who comes after me, and that was just a nail. I remember very well the funeral was on a Saturday. On a Sunday, she sat, early in the morning, she sat on the veranda and said she's waiting for my brother to come for breakfast when the funeral was the previous day. Since then, things just, became different. But there are two things that frustrate me most, that when I go home, when we've been sleeping together, when I visit her, she will ask me, who's this one next to her? That is the first thing that frustrates me. The second one will be that she doesn't want to bath. Yeah, I just wanted to share that we are all struggling with this condition. And having said that, I would like to say thank you very much to Dr. Sizi for coming to our level and break the information. You can see the terminology is quite complicated sometimes, but she has tried to break it down to simple levels for us to understand. We really appreciate your willingness to come to our level, being a specialist, and share such an important topic with us. And as our rector said in his introduction, it is quite a problematic topic. I remember very well I was driving home from Mtunzini, and I stopped there because I saw an old lady with a lot of people around her. And this old lady, when I asked her, she said she's from Tutluwe. Tutluwe and Mtunzini are two different, And no one knew until I called the police. Fortunately, when you're at Mtunzini tollgate, you are close to Mtunzini police station. I had to call the police. Yeah. So it is a problem, as our rector said. So we really appreciate, and we're going to have more of this, Dr. Sizi, in the Upper Highway area. Thank you so much. And on behalf of the rector, Reverend Sizi Ngobo, and the Church of St. Agnes Parish in Kloof, we'd like to say thank you very much with this small token just for respecting us as congregants and share the knowledge. As you said, knowledge is power. We really appreciate that.
Thank you so much. Thank you. Thank you very much, everyone.
Thank you so much. And you remember that about 2 months ago, Dr. Sizi was here on autism. And what happened after the seminar, there was a sense in which we should have a follow-up seminar, not wait for the next year to have another seminar. So we will be having a follow-up seminar on autism. We managed to get hold of Umama Umneli Dunge, and she will be here from, is it Action on Autism, on the 22nd of August. I think in 2 weeks' time, on Tuesday, we will be here on a follow-up seminar on autism. I would like to invite Baba Kenon Temba Vundla to come up and just give us a blessing as we depart from this place. And thank you so much for coming, and thank you so much for joining online. This session will be also available on our Facebook page. So we will share the link for those who would like to go back to it and get more information. Thank you.
Let's bow our heads in prayer, please. Father Almighty, even the hairs on our heads are known to you, and not a single one of them disappears without your knowledge. We thank you for Sizi and for her presentation to us today, asking that you may help us and help those people who are involved in science and finding out about the causes of different diseases, that they may be helped by your Spirit to discover. We pray for everything that we have heard today and for the people that were concerned about some of us, praying that the Lord may guide, direct, and bless the leadership of this church. Now we commit you all to God's gracious keeping. May the Lord bless and keep you. May the Lord make his face shine upon you and be gracious to you. May the Lord look kindly on you and give you peace. In the name of the Father, and of the Son, and of the Holy Spirit. Amen.
Thank you. Thank you all, and have a blessed evening. Thank you.
Where I lose myself, I